we've got some time here to look at some things before we freak out and just go doing something we don't necessarily need to do. Yeah.
We started to see the kiddo looking around.
Okay.
And I was like, okay, I'm feeling better.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
All right, Doc. What are we talking about today?
Well, it's something that actually strikes fear into a lot of our providers. We asked people the two things that scared them the most: work and taxes.
Taxes, yeah.
Is an EKG they couldn't interpret and a kid they couldn't resuscitate, right? Yep. So pediatric patients can be scary, especially the littler they get, the younger they get, the scarier they can become. Mm-hmm. And the whole thing about kids being little adults.
Yes.
It's a misnomer.
They're not just little adults.
In some ways it might be true,
right.
But they're really different. They're unique. A lot of unique challenges.
Do you know why it's scary for those pediatric patients?
I think of a few things.
Well, do you know about System 1, System 2 thinking? I'm sure you do.
Oh, tell me about it.
Well, so System 1 thinking, if I remember correctly, and to give credit where credit is due, this is actually part of the hand-heavy class. They teach you this when you go through their instructor course.
Oh, okay.
and
Yeah, I've never done that before. Like
System 1 thinking is the thinking that we go into when we get like an adult cardiac arrest.
Right.
Like we don't get worked up about it because it's like, yeah, we know this. We know what we got to do. We got to get on the chest. We know what the epidose is. We know what size gel or intubation ET tube we're using. Like we've done this before. It's kind of like automatic. We don't have to think about it. System 2 is where it's like, oh no, like I haven't done this in a long time. I'm going to have to look up. I got to do med math. I'm nervous. It's a kid. I don't know what my epidose is. And so it just completely throws us off, which is why people grab their kids and they run to, as I call it, their whoopee, the back of the ambulance, and then they run to the hospital, right?
Yeah. And
again, as we've talked about before, that is not what we need to be doing. We need to stay on scene and we need to work the problem there not because we're paragods and we want to show how cool we are. It's the patient's just best chance for survival.
One thing I have found, to use your vernacular there, is that in the ER, I do a lot of that System 2, where I don't know what's going on. Mom's bringing a limp baby in and laying it on the gurney. And I got to figure out what's going on.
Yeah,
so
no idea.
Eyes wide open. I don't know what's going on. Systems 2, right? But then once I've narrowed in on, this is a seizure. I think this is a seizure.
We're going to System 1.
We have been System 1, But staying calm, your eyes open to identify and to hopefully be accurate on your diagnosis so you don't run down the wrong rabbit hole is important. Keep your eyes open. Don't anchor too, right? So
definitely don't anchor. You can get yourself in trouble. That way, anchoring, based off your dispatch notes or what you see. But it all starts with a good assessment.
It does. And before we get to assessment, I think it's part of assessment, but before we get there, though, is to talk about how kids are different.
Okay, yeah.
For airway example,
first off, they don't pay taxes.
They don't pay taxes, and they have nothing to be afraid of.
They have nothing to be, boys.
Well, that's a cool thing. That's what I loved about pediatrics, though, when I was in residency and in medical school, too. My first experience with the pediatric population is they're not always, but most of the time, so pure.
Yeah,
and
honest.
It's like they just are hurting.
Not trying to manipulate the system.
Right.
Yes. That's why special. I like them. Yeah, they're very easy to assess. They'll tell you, does this hurt? They'll give you an honest answer about yes or no, or what's the number? Give me a FACES score. Yeah. They're very honest. They're not trying to manipulate.
And even those kids that can't talk. It's, that kid that's crying, that little infant, had a hair tourniquet on his finger or toe or penis or whatever, and you find it and you fix it, and they're
all of a sudden
fine. But they were crying for a good reason, right? Yeah. So I think that when a kiddo's not acting right, it becomes our job as providers to try to do the best we can to figure it out.
And I think that, I would hope that most providers, that's the other level of the nervousness, as we've talked about before, is because nobody wants to hurt a kid.
No.
Nobody wants to screw up on a kid, right? We know the stakes are high, and we don't want that. Number one, we don't want to do that for our patients. Number two, we don't want to do that for our conscience, right?
So young, so much life potential. Mom and dad standing behind you.
There's a lot of
pressure.
A lot of pressure. This is why for new paramedics, new EMTs, this is why we do mega codes.
That's right.
Is because we have to put you in pressure situations to see how you're going to respond.
How are kiddos anatomically different from adults?
Big
What are
heads.
some big heads.
Big
That's right.
tongues.
So for airway, big tongues,
Yep.
anterior airways,
Yep.
large epiglottis. I mean,
Yep.
there are some anatomic airway differences that are huge to understand before you even get to the assessment. You got to be aware of these things.
Lung size, they're going to breathing rates much faster. If you're thinking that the heart rate on a infant is going to be 80, you're sorely mistaken. It's probably going to be double that.
Good point, Matt. Yeah, bringing like being familiar with pediatric vitals
Yes.
and understanding the general trend of how vitals change as kids get older
Yep.
can really be so helpful in assessment.
Tidal volume, if you're bagging these kids like you're bagging adults, like you're going to pop lungs, you're going to cause pneumos. So, yeah, I mean, it's a much smaller system. The heart is very strong because it's young, but it's pumping a lot faster because it's smaller, so it's trying
And
to...
the body surface area to volume is so different too, and it creates problems with thermoregulation,
Right.
Positioning a patient for airway,
Right.
all of these things, and then using the right tools to the right size.
Yep.
The Broslow tape is one thing. Antevi's got some other stuff with dosing, and
Yep.
that's another. We'll get to that later with management, but there are so many different considerations for the pediatric population.
Length, height, weight.
Yeah.
Weight.
Height and width.
Height and weight. It's a very big problem, Dr. Axene. They are a scary, unique, and then you look at the med math, right? Traditionally, and like you said, we'll get to that. But that was the other factor that always plagued pediatric calls is that, oh my God, I'm going to have to do algebra.
Which is,
right?
and that's part of the whole genesis of the Antevi system,
Yes.
Peter Antevi.
Yeah, and for the record, like we're not sponsored or we certainly
We're just looking-
we do like the Antevi
it's a great
system.
product.
It is a very good, effective product.
Yeah.
I've worked with them. It's also a very good company. All their people are very good, but it is a very good product.
And it's been compared
Yes.
statistically to have no statistically significant difference with the Broslow tape, which uses height versus age, what the Antevi system uses. But the great thing is you don't need the tape.
You don't need the tape. Well, and not only that, but Broslow doesn't give you the mLs.
That's true.
It just tells you the dose. You still got to do math, right?
That's right.
So anyway, we'll get to Antevi more. But yeah, kids are not just little adults. There are some differences there.
And I think one of the most important big rock type differences here is that the little kiddo, they crump fast.
I was just going to say that. Dang it, you took me.
Well,
You took
they-
my thought. Yeah, they decompensate very quickly. Yes.
But they hold on for a long time,
Yes.
looking pretty good.
Yes.
And
And
then
then-
when they fall off quickly. So they can, when you're seeing a sick kid, you may not have the amount of time you do in an adult.
That's right.
Those are important.
Yeah.
And I think, and as we get to it, we'll talk more about it with assessment. But there are certain things that we can see in kids that we really can't see as clearly in adults. And I think that helps us. If you know what to look for,
Right.
it's really a special thing that really can help you with pediatric assessment and management too.
Yep. Well, you want to get to the pediatric assessment triangle?
Let's do it. So 3 parts here, and we can break down each of the 3 parts.
Yeah.
I
mean, there's different ways that they say, work of breathing, but basically it's, appearance, work of breathing, and circulation of skin or circulation is kind of the respiratory work of breathing. Different people say it different ways.
These are I like to call them doorway signs. That's,
from the doorway.
When I'm teaching baby doctors I used to work as an attending physician. I'm teaching doctors how to assess patients and trying to help them to understand the value of what you can see from the doorway.
Absolutely.
These aren't necessarily from the doorway, but they're
well, appearance is
Yeah.
What does a kid look like?
Right. So these are really really helpful, and it's gives you, if you're new to being a paramedic or an EMT, this gives you a good framework to work from for a pediatric patient that might at first be like that. What did you call it, level 2? No, he calls it
system 1 or system 2 thinking.
You're not quite sure what to do.
Yeah.
Well, this gives you a little bit of a system 1 type of an approach where let's start with work of breathing. You can see work of breathing from the door.
Right. You can see skin color, which is part of appearance, but goes to work of breathing.
Yeah.
Do they have bluish lips?
Yep.
You know.
And then the appearance. And appearance might be as simple as looking at me from mom's arms and sitting up, or
completely limp in
playing
mom's
with
arms.
mom's phone. I mean, these are these are things to write down, whereas the appearance might be asleep or whatever, and you wake up the kid, they're lethargic and hardly responsive. I mean, the appearance of a kiddo can give you big clues. If you walk in and kiddos crying like crazy, that's actually a good thing. You can see the work of, you can see them, the airways patent.
Yep.
And you can also see the kiddos got a lot of energy.
Yeah.
Fighting something. Something's bothering the kiddo, whatever. We can figure it out. But as far as the, a kiddo that's crying is usually healthy.
Yeah, that's a good sound when you're in the ambulance.
Right.
Most people get irritated by screaming, crying children. Paramedics and EMTs do not, because that means that, okay, my kid's doing okay right now.
That's right.
They're not, it's when you have that limp, quiet kid that you're very concerned.
And appearance.
Yes.
You can see the skin color, the circulation of the kid.
Pale.
That's huge.
Yes.
Huge. Blue,
Yep.
pale, red. I mean, there are certain things that can be signs to us based on appearance that can really help us. So sorry, with the circulation.
No, yeah, you're good. Yeah, you see them, you come through the door and you see that kid, like, again, what do they look like? What does their skin color look like? Are they interacting with you? Obviously, that depends on the age of the kid. Infant's not going to interact with you, but are you dealing with a 3-year-old? If you have a 3-year-old that freely comes to you, like, that's weird. That's unusual. He'd rather come to you than mom. Yeah. Are we dealing with a child abuse issue, or are we dealing with a medical problem?
Holy smokes, yeah.
But so, like things that, like, this 3-year-old, why is this 3-year-old walking up to 5 dudes they've never met before when mom's right there? Yeah. These kids naturally will gravitate towards their parents, their guardians. Yeah. They will be clinging to their leg. They don't want to talk to you. They don't want to interact with you, right? That's why we use mom and dad as a helpful tool to communicate with the kid.
Well, let's break down each of the 3 parts of the triangle. Let's start with work of breathing and talk about some of the things that we can look for. That the way that a kiddo breathes can give you a lot of clues onto what's going on. It's that RSV season, and you hear that barking cough, maybe a foreign body. You hear like a stridor, an inspiratory stridor, or whatever. I mean, there's a lot of different things you can see with breathing, especially with upper airway. Yep,
tugging.
That's right. And that's breathing. The other thing. Yeah, so. That's something I like to teach is when you're looking at the work of breathing, a kiddo should not be working hard to breathe, right? But you see a kid at rest who has got some belly movement. That's where things usually start. Right. Now I'll say that with little kids, sometimes the nasal flaring can be your clue, but with kiddos, typically starts down low, belly breathing, and you can see the belly moving with the breaths. That's not normal.
Yeah.
You may see a little bit of movement of the belly with the diaphragm going up and down, but typically that's not normal. And then as things get worse, you start to see the costal retractions or sternal retractions and the sternal notch, the sternal tugging as you move up. That is a bad sign. You start to see the neck, the sternal tugging. That's the kind of breathing where you've been breathing poorly for a while, and now we're in extremis here, and now we better be ready to take emergent action. So those are the kind of basics. Now, another thing I'll mention with the work of breathing too is the sounds that you hear, right? It might mean listening to the lungs. You hear the wheezing. You might hear the stridor just from the doorway. Yeah. There's doing the full assessment of the work of breathing is it's not a simple task. There's a lot to it.
And you have to manage, or you have to prioritize management with assessment, right? If you walk in and your kid looks cyanotic, they've got bluish lips, they're breathing super fast, like, don't be getting out your stethoscope and put the kid on some oxygen. We've talked about this before. Like, get them on some oxygen, some blow-by, whatever the case warrants. Get them on some O's, quickly if that's needed right away.
I've also sometimes I'm careful with that because I know that with a kiddo that's got RSV, I can irritate them and then make the stridor worse.
Epiglottitis, those kids hanging, croup, same thing. You don't want to tick them off because that's going to make it a lot worse.
So there's some experience involved here in knowing exactly how to approach these kids, and sometimes I do it differently.
Right. That will depend on how the kid's interacting with you, for sure.
So then, so work of breathing, and then we go to appearance. Yep. I mentioned this earlier, but when I walk into a room and kiddo's on mom's phone, I document that on my chart.
That's a good thing.
That's a good thing.
Yeah.
You see kiddo
they're relaxed.
Playing, right?
They're playing.
Yeah, is asleep in mom's arms, or was nursing, or the fact that the kiddo was nursing in the exam room, it's a kid that's feeding. A kiddo that you can see has got a full big old wet diaper.
Yeah,
these are
good.
good things.
Yeah.
So appearance, you can see a lot from that doorway. But the most important thing I would say would be the appearance of a kiddo when you walk into the room. You want a kid to be a little
scared,
bit
nervous.
scared, to be a little nervous of you, to make hold on to mom's arms, and when you're doing your physical exam, they're fighting you a little bit.
Yep.
I think these are important things.
Yeah.
That work towards
the look, the gauge, speech. Are they crying? Are they happy? Do they seem content?
and document it, and then finally the circulation. So this is, you mentioned earlier, so we see that with skin color.
Yep. Yeah, they
cyanosis potentially, or mottled skin with sepsis, or maybe there's some sort of a. I had a patient once from the door. I could see this kid looked like a China doll. Just white skin.
Oh, yeah.
Hemoglobin was about 2.
Oof.
Very, very, very anemic kiddo.
Yeah.
Mom and dad just thought he wasn't getting enough sun. But this kiddo was really sick. And it really, I have pictures. I mean, it's just white. The skin was as white as this paper.
Yeah.
It was really, really impressive. But that's an appearance thing, right? And that's a circulation thing. And that's, all of these things kind of come together for one picture of the patient in your assessment of the patient. Then you can dig in deeper, because that kiddo is breathing, looks like they're breathing rough. You do your lung exam very carefully. Right. You see that skin looking a little bit, the appearance of, or circulation of the skin. You see that, right? You're getting in and looking at the subconjunctival mucosa to see if there's pallor there, the oral mucosa, the hands, the fingernails,
cap refill,
all of those things. And then you, with the appearance, you're doing your exam and you're watching how kiddo responds to you.
Yeah,
these are huge. This is a good place to start.
Yep.
Anytime you're doing pediatric assessment.
Yep.
So Matt, you went through that. And the hand-heavy course.
Mm-hmm. Yeah, the instructor course. Yeah,
I think that can be a huge part with pediatric management. You've seen your patient. You've studied the pediatric patient. You understand some of the anatomic and physiologic differences. And you've done your assessment. You used your pediatric assessment triangle to get it started. You finished your assessment. You have a pretty good idea what's going on. Mm-hmm. Talk with us a little bit about the hand-heavy system. There are many systems out there. Mm-hmm. We're not a proponent of any one in particular. We may favor one over the other, but we're not.
I have the most experience with hand-heavy. I'll say that. Yeah, like I've used Broslo, but I definitely have the most in my career. I've used hand-heavy the most. I find it very user-friendly and easy to use. But yeah, I mean, and the whole. I think it's important to again talk about. This all started with Dr. Antevi realizing that we've got to get first responders to slow down, to stop rushing to the ambulance, to stop rushing to the hospitals. We've got to get them to stop and treat the patients on scene. And this is something that's crucially important. This is a philosophy, this is a mindset that we struggle with in the fire service, especially people that have been doing this for 20, 25, 30 years. Right. They don't understand this. Why are we staying on scene with these kids? We need to be getting them to the hospital. No, we don't. No, we absolutely do not. Do you want to save this kid, or do you want to feel better? Do you want to be more comfortable and just be over this call, right? And our job is to treat the kid, right? And the data overwhelmingly shows that the best chance of survival that patient has is for us to stay on scene, calm down, and start working the problem. And
with like a pediatric resuscitation. I mean, some trauma situation.
Yes. I'm sorry. With a pediatric medical cardiac arrest. Right. Yes. Obviously, with trauma or something, you're going to be moving to the hospital a little bit faster. The good news is that most pediatric issues are respiratory.
They are.
Most of them.
We talked about this in some of our courses.
Yes.
Vast majority. It's not even close.
No. So, addressing, assessing quickly the respiratory. Just like we talked about in the last segment, the respiratory drive, their appearance can tell you about, how well they're breathing, circulation, all those things. But most of your problems are going to come from a respiratory.
Especially with neonatal resuscitation.
Yes.
The surfactant, which we've talked about many times, is something that, especially in a premature neonate.
Yep.
It's going to be a problem.
Yes.
And even in infants. I mean, but the respiratory system itself is working, but the lungs haven't quite developed fully, and they don't have that surfactant or whatever to keep those lungs open.
That's right.
That's a big reason. So that's oftentimes why too with drownings. Totally different issue, but very similar.
Yep.
Is that the rescue breathing is so important
Yep.
to do that first.
Yep.
Yeah, because oftentimes it can, like you're kick-starting your dirt bike,
That's
you get
right.
those rescue breaths in, it can start everything up again. So it's important.
Yeah, very important.
So back to hand heavy, sorry.
Oh, no, you're good. So, yeah, hand heavy. So, I mean, it kind of started off with the hand heavy method, which I think most people have probably heard of this. You know, you've got your hand and you go off patient's age 1, 3, 5, 7, 9.
Yep.
Right? And then 10, 15, 20, or 10, 15, 20, 25, 30 on kilograms.
Correct.
For your different patients. And then you go in between there. You can look
So
this
if
up.
they're
Right.
between 10 and 15 at 12 and a half.
Exactly. 12 and a half kilos.
And it's big kilos. And it's really amazing how accurate it really is if you've got a good idea of the age.
Yeah, for sure. It's very accurate. And like you said, they've done studies and just ballparking. Like if just ballparking it, you're very close. There's no statistical difference as sitting down and figuring out exactly what dose I need. This is close enough. Get it. And it's much, much faster, much easier to remember. The other thing is, do you know about epi and amio doses? Is that your 1-year-old, 10 kilos, all you have to do is move the decimal point.
Okay.
You're going to give 1 ml of epi. This is in a cardiac arrest situation. 1 ml of epi 1 to 10, 1 ml of amio. And that goes all across the board. For a 15 kilo, it's 1.5 mLs. For a 20 kilo, it's 2 mLs. So you already know your dosages for those. And they actually talk about, and this was a huge takeaway for me, is getting out of that system 2 to system 1 thinking, is pre-planning. You get that call, the call that we all dread, 4-year-old, cardiac arrest.
You know it's for.
Yeah. Well, I mean, hopefully they say, it's 3 or 4.
No, but I mean, when you know it's for, you can start to
When
think
you
about
know
these
for
things.
yes, or that's what the dispatch notes say. Mom called 4-year-old male unresponsive, performing chest compressions. Right? You get out your app, and you can pull up. And again, the Hand Heavy app's a great app. It has more than just dosages on it, but you can look up equipment sizes. So they talk about knowing the age, the kilograms, how much epi, because there are studies that show that the faster you get epi on board, the better outcome the kid has. So that's crucially important, is knowing what the depth is. And then your eye gel or whatever, supraglottic airway tube size you use. Getting on the chest, getting the ventilations, getting an IO or an IV ready, and then getting that epi on board is crucially important.
Yep.
That's the first things, and all that information before you get there. Hey, you're going to throw in System 1. But you're going to get there, Eric, I need you to put in an eye gel, a number 1 eye gel. Yep. Matt, I need you to get on compressions. Jimmy, I need you to get an IV or an IO, and the epidose, he's, 15 kilograms, 1.5 mLs. I don't care what the dose is. I need to know how many mLs it is.
Right.
Super important. That way, now we walk in and we're not freaking out.
Yeah.
We walk in and we're like, we know what we have to do.
Yeah.
And we set it up right, and we train over this, right? But we set it up right, and everybody goes to work. And what does that do for the parents, too? If we're freaking out, throwing things out of the bag, and we're freaking out, that's not making mom feel any better, right? When we walk in calm, we get our bag out, we know exactly where we need to go to get the eye gel, or whatever the thing is. We know exactly where we got to get the IO drill, the epi, and everything's going smooth. It's like, hey, these people know what they're doing. And you do. And that's helping out your patient tremendously.
And you can incorporate that into your training. And
Big time.
the thing I really like about this system is that it frees brain RAM, I like to say.
Yeah.
It's like a computer's got a certain amount of RAM, like a desktop of what it can handle at the same time. The brain's the same way. And we all have different amounts of things that we can handle.
Yeah.
But
I'm in the megabytes. You're in the
megabytes.
gigabytes.
Oh, gosh. But we have
Yeah.
a limit to what we can handle
Yes.
in our mind at the same time. And by having these sorts of checklists and systems
Yes.
that we can
It
use
makes
for
it simpler.
medications, it takes something off of the RAM of our
Yes.
brain so we can use more of our brain to do that critical thinking, to identify disease processes and
Yes.
things that checklists can't help you do.
Yes.
That's one of the reasons I love that. And I love systems like that.
Yes. That are helpful for anybody. I mean, when you think about the level of things that we have to know as first responders, right? If you're a nephrologist, all you got to worry about is kidneys, right?
Yeah.
You're a master with kidneys. Obviously, they go to med school, right? But like emergency room physicians, like I've got to know how to deliver a baby that may be breech,
Right.
and then manage the baby and mom and resuscitate them. I might go from that to a major accident trauma. Like, we have all this stuff we have to know, right?
Totally.
Super complicated. So the more systems that are in place that help us, like you say, free up RAM in our brain, makes it, I don't know if simpler is the right word. It takes a lot of the stress out of it for us, and we're able to perform better.
Do you remember a chief I introduced you to? He's from Washington. I think he was from Skagit County.
That's where I got married.
Oh, you did?
Skagit County,
Oh, really?
Washington. Oak
I
Harbor,
didn't know that.
Washington. Yeah.
Really?
No, that's
I
I'm
know
sorry.
you're from Snohomish
No, Skagit
County.
County. Yeah,
That's
my
right.
wife's from Snohomish County.
'Cause that's just south of
Yeah, Skagit is south of
And I could be wrong, so if Chief Maxwell, I'm wrong, I'm so sorry. But,
Sorry, Chief.
But we got to speak together.
Yeah.
And we really, in Phoenix, we spoke together.
Was this the guy that looked like me, or somebody thought it was me, or something? Who
No,
was-
so he had a friend named Matt Ball.
Oh, that's what it was. Okay.
And we thought we were talking about the same person. We realized we weren't. He was nowhere near as handsome. So. No, but
Poor guy.
we were talking about this, and he went and talked to jet pilots.
Oh yeah, I
And-
remember this.
Yeah, and to decrease errors,
Yeah.
they would form checklists.
Yeah.
And they go through and pilots do this.
Yeah.
And it's like, why don't we do this?
Yes.
And so he actually developed this system using checklists, which was brilliant.
Yeah.
And that's really what's happening here.
Yes.
Is that we're doing things to simplify and decrease errors
Yep.
and to improve the quality of care we deliver to our pediatric patients.
Well,
Because
yeah,
this is a huge source of error.
Yeah, it is, and it creates a lot of stress, and that's this. Hand Heavy's taken a lot of stress out of that situation. It's still stressful, obviously, but it's taken a lot of that guesswork and the stress out.
No, it really has.
And then, one of the things that they talk about too is ideal body weight versus actual body weight. And does it matter how tall the kid is? Does it matter how fat the kid is? I get this question all the time, like, ideal body weight. Well, what if the kid's 10 years old and 300 pounds?
Yep.
Well, it matters what medication are we pushing, right?
Yep.
And is it fat soluble or water soluble, or what's the lipid hydrophilic?
Hydrophobic.
Yeah, phobic.
Lipophilic and
Yeah.
hydrophilic. Yeah.
Yeah. So going into water or away, absorbing into water or fat, right?
That's correct.
Yeah.
Yeah. So compounds like water, this would be hydrophilic, and so it's charged, and so it will enjoy a charged environment.
Right.
Whereas-
So ideal body weight is what you want to go off. Which with most of our medications
Correct.
pre-hospitally are hydrophilic.
That's correct, because the blood, these medications go into the blood and they distribute them throughout the body, and they won't distribute into the fatty tissues
Right.
because that's lipophilic.
Right.
Now, if you have a medication that's lipophilic, you got to be careful
Right.
because it can just to be aware of it, because it'll dissolve into the lipophilic tissues, the fat tissues, and then so now the ideal body weight may not be the ideal way to dose these medications. So
Right. So that's important to keep in mind. And then, but the length of the kid, how tall the kid is. Now that comes into play with tube size. You and I are the same age, right? But you're quite a bit taller than I am, which
So
isn't saying much. You're like 5'8", and you're tremendously taller than me. No, I'm just kidding.
well, relative to
But go ahead.
no, you're right. I mean, there may be some differences based on our height, but
Yeah, equipment-wise, like especially ET tubes,
Yeah.
right? I'd probably put, if I had an 8 or a 7.5, that's probably what I'm going
probably
with.
at least
in
an 8, I would say. And
Yeah,
then-
in you.
Yeah.
Yeah.
And I think that you don't have. I mean, you could probably fit a bigger one, or maybe smaller, and that'd be just fine.
Right. Everybody
But
says I
think
have a big
most
mouth.
men. Most men, like you said, 7.5 or 8.
Yeah.
Most women, 7 or 7.5.
Yeah.
I mean, it's just
It's funny how we do. Yeah, I was recently doing some mega codes, and as we're going through them, the doc always asks, like, "What size tube are you going to use?" It'd be a 50-year-old male. We'll do a 6.5, and he's like, "Why are you doing that?
Yeah.
Why are you doing that?" He's like, "No adult men should get anything less than a 7. No, none. Period. Just
unless
that
you're gonna
simple."
cry.
Well, yes, and that's what he says. He goes, "What size do you?" He brings that up. But yeah, but oral innovation. If you're out there using smaller than a 7 on pretty much any adult, unless it's like little 80-year-old tiny grandma, it's you want to get the biggest size tube you can.
But with kiddos, the great thing too is these desk references, these mobile devices can help you.
It's all in the app.
That's
I just
right.
pop up the app and I know exactly what size I'm supposed to
It's
use.
actually not very complicated too. I mean, you think about it. You get a kiddo. The smallest size is a 3,
Mm-hmm.
and as you get older, the adults are up at a 7.
7, yeah. So you don't have lots of room for.
No, it's
got some half sizes and stuff,
yeah.
but
so there's some margin for error, but and there's also the cuff versus non-cuffed. I mean, there's a lot of things here, but we're not going to get into those nuances. But these apps though can be really helpful, and you don't have to worry about calculating tube size. It's
Correct.
there for you.
It's all
you don't
there
have to
for
worry
you.
about drug calculations.
That's
it's
right.
all there.
You just got to work the patient. Yeah, it's. So again, the fat soluble versus water soluble, it's all based off ideal body weight, which has been proven a very effective way to do it. No statistical clinical difference between the two. Height wise, you might want to look more at if you're using equipment. Go for the get out the tape and measure them that way.
Right.
But the important thing is that you have to train on these patients, right?
Practice.
Yeah, you got to practice with these patients. You can't just be always talking about STEMIs and breathing difficulty with adults, right? You have to run your crews through a pediatric arrest scenario. You have to do it because they're few and far between, thank goodness. But we have to be ready when we get them, right? We have to be every bit on point when we get them. I remember we had a pediatric arrest. I was fairly new. I'd been out of paramedic school maybe 2 years, and I was not on the ambulance that day. And we got a pediatric arrest. And long story short, like after the call, there were some things that went good and there were some things that went not so good, right, on the call. As most calls, that's what happens.
Always room for improvement.
Always room for improvement. But there were some things that like really didn't go well. Yeah. And I remember this captain who was really well known as being a very competent fire captain, right? Pulling us all into the room after this call. And he was not happy. And he was not happy because he's like, that is the 1% of calls that we absolutely need to be ready for. Yeah. And I was impressed with the fact that he was kind of known as this really good fire captain, right? But he never really, not that he negated EMS, but he took that EMS call very seriously. And the things that went wrong, he's like, that will never happen again. He goes, that's unexcusable for us to make these mistakes in that call. That is the call where we need to absolutely be on our game. And I respected him for it. And he was right. And so, yeah, we have to get out. It's better to be uncomfortable in training than be uncomfortable on scene.
Yeah, we talked about that in previous episodes here.
Yes.
That's what training is for.
Yes.
Make the mistakes while you train.
Yes, make the mistakes. Screw up, right?
But you're okay, though. You got to live with yourself if you do make a mistake when things matter. Things happen. And I think that's why, like what your captain did, which was so brilliant, is to debrief afterwards.
You have to do that.
We recently had a tough patient in the ER, and it was a difficult situation, kind of pushed us a little bit, and we debriefed afterwards. What went well, what didn't go well, what could we do better, what could be praised, right?
Yeah.
There are always things to learn. And it went pretty well, but there's some things that happened that we don't want to have happen again.
Yeah.
No bad patient outcomes, but there's always something to learn. And debriefing afterwards, we didn't add it and talk about it until now, but I think that's a really important part of working together.
You think about a football team. You've been the physician for the Dallas Cowboys. All those guys do is just train and train and train. That is their whole life. Like Tom Brady, that's all he would do is preparation. He would just master the playbook, master the defense, watch hours and hours and hours of film. That's really where you win the game, is all that prep work, right?
That's right.
And then you're out on the field and you're practicing. Think of all the practice and time they spent to play a game for an hour. And then how many mistakes did they make in that game? Hundreds. Tons. They make constant mistakes. Or if they didn't, we wouldn't have referees throwing flags every 5 minutes, it seems like, right? Yep. And so the just think about the level of preparation to be an NFL football player is just, those guys, I'm sure it's, 12, 16 or more hours a day prepping. And then on game day, they still make mistakes. Yeah. So for us to think that, I've trained on this enough. No, you haven't. Especially when a kid's life's on the line, there's no way you could sit there and say that you've trained enough for that situation. So anyway, just a thought that popped into my little brain.
Well, actually, I love it that you brought the football analogy in. There's something about prepping and training that really equips you to be able to handle the game day changes and obstacles that you encounter. Rudy Giuliani, I've told you this before, said the best way to prepare for the unexpected is to over-prepare for the expected.
Yeah.
And I think the same thing is true for kiddos when we treat them. We're over-preparing. We practice and we practice for those things that might happen that we don't expect.
Yep.
I remember when I was coaching football, one of my favorite parts of coaching, where I felt like I could shine as a coach. We may not win the game, but as a coach, I could change the tactics and the strategies at halftime to better compete against the team now that I've seen them, and I can make adjustments. And then, we were down 21-0 in the first half, right? But in the second half, we shut them out. We lost 21-14, but man, I as a coach, I felt like we really won that second half.
Yeah.
And I think it's true with pediatric patients. You start out, you think you know what you're doing. You may have to pivot. Like, wow, I thought this was seizure, but no, I don't think that's.
Yeah.
And you pivot.
Yep.
I think not getting so stuck in what you think it is and anchored, like we talked about, and being willing to pivot and adjust your way of thinking, and not be too prideful, and humble yourself a little bit,
Yep.
and take care of that patient first. That's why we're there.
I'm laughing a little bit because you talked about the seizure patient, and I remember we made a call one time, seizure call, 18-month-old. Fire apparatus had got there first, and myself and my partner walked in, and as we were walking in, they were disrobing the kid, getting ready to put it in the bath. So what do we automatically think when we think a 18-month-old having a seizure? It's febrile.
Right.
Febrile seizure. Kid's got a fever. That's 99% of the time, right? That's what it is, right? So I'm walking in. They're taking the onesie off the kid. They're getting a tub ready to cool it off a little bit. And I'm like, hey, what was the temp? And they're like, oh, it was like 98, whatever. And I'm like, so why are we trying to cool the kid off? Like, it didn't have a temperature. It hadn't been sick. But they got so locked in on, well, it's an 18-month-old that's having a seizure. It's got to be febrile. Like, no, bro, they don't have a temperature. Mom is saying the kid has not been sick. They're not hot to the touch. Yeah. There's something else going on here. And sure enough, kids started seizing again. Right? And so now everybody's freaking out because now they thought, oh, we'll just take the onesie off. We'll cool the kid off. It won't have any more seizures. We're heroes. We can go back and eat ice cream, right? Now it's like, oh, crap, I've got to do algebra and figure out how much Versed I've got to get this kid, right? So, yeah, preparation is huge because they will turn on you in a heartbeat. But that brings up the point of don't get the blinders on, right? Yep. You've got to keep, like, just because it's this 9 times out of 10 doesn't mean the 10th time it's going to be the same thing. Yeah. You have to be ready to, like you said, make that transition.
Yeah, no, you do. I had a similar situation in the ER not too long ago. I think I may have told you this story. Mom brought in limp 4-year-old kiddo into the ER, kind of banged on the ambulance bay doors, and here she is.
Yeah.
And now I'm in room 4, and I got this
4-year-old.
No
call, no time to prep. Here you go.
Unresponsive, no idea what's going on. And again, like we talked about before, what do I know?
Yeah.
Get some information, start assessing the kid, work of breathing, looking at
appearance.
Looking at the appearance,
circulation,
looking at all these things. And you start to get some historical clues, and it started to move toward seizure. And it started to make more and more sense. But the SATs didn't look good. Vitals weren't looking good. Kiddo wasn't looking good. Not seizing that we could see. But I thought, well, this is probably a seizure, so let's prep the airway drugs, and we'll watch for some improvement, because if this kiddo is post-ictal right now, we should see some improvement. But I wanted my nurses to get all the meds ready for intubation, potentially if we needed to protect the airway. And over time, over the next few minutes, which felt like an eternity, we started to see the kiddo looking around.
Okay.
And I was like, okay, I'm feeling better. 30 minutes later, the kiddo was up, sitting up and talking to mom and totally fine, and transferred for a pediatric seizure.
Yeah.
We did our workup appropriately and all that. But the point is, though, is that sometimes you just got to slow your roll a little bit and not be too quick to act.
Yes.
It wouldn't have been bad necessarily to quickly intubate that kiddo, because based on what they look like, they should be
Could have
intubated.
justified doing it, right?
Right.
But that doesn't always mean
it's not always the best thing for the patient.
Right.
Get a good history, get a good idea of what's going on with the patient, and then watch them carefully, reassess.
Well, and that's like we said at the beginning, like, what's your appearance? What do they look like? Now, if that kid was not breathing and had blue lips, you'd tube the kid right away.
Right.
Right? Because it's like, okay, yeah, this is obvious. The kid's not protecting its own airway. It's not breathing currently. We got to get an airway in.
Yeah.
Right? But that's where experience comes in. It's just where, like, everybody freaks out when they see that limp kid, but it's like, okay, hang on. Like, is it breathing? How is it breathing? What's the appearance look like? What's the cap refill? What's, let's listen to lung sounds. We've got some time here to look at some things before we freak out and just go doing something we don't necessarily need to do. Yeah. That's Jerry Wells said that. I think he said that in our podcast.
Love that guy.
Yes. But I'll never forget that. He pulled up on a big, huge fire on the highway, and he goes, sometimes something so big, you just got to get out and just take a deep breath and go, okay, this is what I got to do. And that's where those checklists kind of come in handy too. Like, okay, I got to do this. I got to do this. I got to do this. Yeah, exactly. It's very important.
What do you say we practice some of what we've been talking about? Is that a good idea?
Let's do it. All right, so you're going to quiz me. What are we doing here?
Yeah, let me. I'm gonna throw a couple pediatric patients to you.
Okay.
It was actually same shift, and we'll paint a picture as if they were, you responded to their home.
Okay.
So dad and
Is this the
daughter-
same time, or I'm doing one at a time?
Oh, dude. Well, actually, they came in at the same time.
Yeah, for you, they came in at the same time. Okay.
And so we can talk actually about multiple.
So I'm at a house,
patients.
and a bus crashes.
So first patient, 7-year-old, was wrestling around with dad. Glass coffee table broke while they were roughhousing, and the 7-year-old got stabbed in the abdomen, left upper quadrant, with a piece of glass, larger piece of glass.
Okay.
And they ended up coming in by private vehicle, but what I want you to do
People that really should call 911 don't.
Right. So this one, I want to go through your assessment, your doorway assessment of this 7-year-old patient. Like what type of things would you ask me, and I'll give you the information.
Right, like so the call would come in as a stabbing. Obviously, that's going to get everybody's blood pressure up a little bit.
That's right.
Walk into the house, I'm immediately looking for the patient, and is my patient, number one, are they conscious?
Totally
right?
conscious, talking to you, seem really well appearing.
Okay, they're A&O, GCS 15.
Everything's normal for this 7-year-old kid.
Okay.
Dad feels terrible, obviously.
Slowing down, so everything like, all right, everybody pump the brakes. Kid's awake, talking, so that's a good sign, right? So I'm assuming that obviously, what's her skin look like?
No, everything looks great.
Everything looks great.
Skin color, great.
Work of breathing looks fine.
Work of breathing's
good
fine.
skin color, you said.
I remember the kiddo being a little bit nervous to be there.
Sure,
but
and just got stabbed in the abdomen.
Yeah,
She's probably not feeling good. So my initial impression is I'm good. Like, let's not freak out here. We're good. Is the bleeding controlled?
Bleeding's controlled.
Has the glass been removed?
Dad placed I think he had come in initially with a towel, but we have now in the nurse's assessment, we had placed a 4x4 with
The
some
glass
tape,
got
but
removed.
no active bleeding. Yes, he took the glass
Oh,
out.
Dad did. Okay, so before we get
So
there. Okay,
a large piece of glass. I guess if you were on scene, you could have seen the piece of glass.
Sure.
But he described it as a large piece of glass. But it's hard to tell exactly how far the glass went in, which I remember trying to figure out. But
large is subjective. Yeah, so the glass has already been removed. So bleeding's controlled, bandage the wound. Obviously, you said upper left quadrant.
Never remove.
Yeah, no, right.
The
Right.
object
Yeah, we
that's
would not ever
never-
remove
yeah,
anything.
and
Yes.
So if you do see a patient like this,
Yes, we would stabilize that
Yeah,
in place very, carefully.
Yeah.
And because obviously pulling it out could cause a lot more bleeding. So, but it's already been removed. So bandage, you said upper left quadrant was where it was at?
upper left quadrant. Yeah.
So again, a little bit worried about maybe a splenic injury.
Good. Yeah, it's good to know the anatomy. That's good. I'm glad you brought that up. Knowing the spleen's here, what's on the right side? You got
Liver.
the liver there.
Yep.
2 organs that with penetrating trauma
A lot
can
of bleeding.
bleed a lot. Yeah.
A lot of bleeding. Yeah. So that would be my main concern is that she injured her spleen. Right? Do I see a lot of blood on the ground? That's another thing. Okay, so not a lot of blood on the ground.
A
So
lot of blood.
I'm
a lot of glass.
vitals are stable.
Vitals look great.
Okay.
Our vitals are totally
So I'm
normal.
sure she's probably in a little bit of pain, right? Probably not overly comfortable, but vitals are all stable. She's alert and oriented. I'm not overly concerned. Obviously, I'm probably going to get an IV on this kid to give her some pain management while I'm taking her to the hospital or while I'm in the hospital.
Where would you take this patient? Like you're
Trauma center, for sure. Yeah,
exactly.
trauma center that can deal with a, how old was she?
7.
7. Yeah, trauma center that can deal with a 7-year-old with a penetrating abdominal wound.
Exactly.
For sure. Yeah, and again, I'm not, regardless of where you're at, I don't have to fly this kid. The kid's perfectly stable.
Yeah.
I've got the ability to manage her pain en route, right? I'm watching her vital signs.
Let me ask you this. So based on your assessment, what signs would you see that would concern you It's like 5-alarm fire kind of stuff.
Yeah, the altered mental status.
Good.
Unconscious, altered mental status, poor skin tone. Obviously, if she's pulseless or massive amounts of hemorrhaging. I'm seeing evidence of massive amounts of hemorrhaging. A high shock index, right?
Yep.
She's got a super high heart rate and a super low systolic blood pressure. Oh, crap.
We talked about this in our hemorrhage lecture, but the first thing that changes, vital sign, right, the tachycardia. If you're altered, you got organ dysfunction. You've gone beyond just hypotension. Now
You are no longer perfusing the brain. It's very sensitive to changes in oxygen.
That'd be a bad sign. That's
Yeah.
good.
Yeah, that would be concerning.
Yeah, I think the other things I might mention, if I was assessing a kiddo like this, things that would concern me, don't ever forget about non-accidental trauma. You gotta remember that.
Yep.
And then I would also say when you're doing your assessment is to look, if you're worried about hemorrhaging, is to remember the conjunctiva. There's some physical exam pearls that we've talked about and taught before.
Yeah.
There's like the window into your blood, like your tank. Is it full or is it empty, right?
Yeah.
So that'd be the only
Not
thing.
one.
Good job.
I doubt that that's really taught. I know I was not taught that in paramedic school.
Let's do it again.
Looking at that conjunctiva is probably something that not a lot of people are being taught as paramedics or
That's
EMTs.
right. One of the first places I'll look when I'm concerned about bleeding would be the conjunctiva. I had a GI bleeder patient that came in just last week on a shift that I really caught because of the conjunctiva was so pale. It wasn't the chief complaint, wasn't necessarily something like a bleeding, it was abdominal pain. But the concern was a perforated gastric ulcer that caused the abdominal pain, and the bleeding had been going on for quite a while, and the patient was very anemic.
Interesting.
The lips, the tongue,
lips,
the palms, the creases in the palm. So while that patient, and I'll never forget, I was actually in the hospital. We weren't at their home. And this, like I told you earlier, they walked in. But I was in there with our trauma surgeon assessing this pediatric stabbing when bang, 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 and a bunch of chaos over by the ambulance bay doors. And your next patient was brought into you.
Were those gunshots or was that
banging on the doors?
Oh, okay. I was like,
oh no,
that's a bad day in the ER.
So as an infant,
Okay.
you could see the jammies. This little onesie were singed. This kid was brought in by law enforcement, been involved in an accident, ejected from a vehicle, picked up by a good Samaritan on the side of the road actually, and per report was on fire.
The kid was on fire?
The
car?
The kiddo.
Oh.
The pajamas were on fire. Anyway, so here's your patient. They brought it into one of the, let's just say you bring it into the ambulance now, right? You're on scene there in the ambulance, your patient. How do you approach that emergent pediatric assessment? What do you do there, Matt?
I'm assuming that this kid, again, appearance, mental status is this kid.
Unresponsive.
Yeah, so airway is my number one concern.
Yeah.
With the burns, I'm assuming that they were probably in some car wreck as well.
That's correct.
So there's also maybe some blunt trauma that I need to be concerned about.
Yeah.
But highest priority, has a pulse, I'm assuming?
Pulses are there.
So has a pulse, but not, what's my respiratory rate? Are they breathing?
They're breathing, not breathing great, if I remember correctly.
But no
soot
or anything?
Yes,
So,
singed burns. All of the exposed skin had signs of burns. On the
my
hands
number
and
one
the
airway,
face.
or my number one concern is I need IV access, and I got to get an airway in this kid right now.
Good. Yeah, you know what? We talk about pediatric assessment triangles and all that stuff, but in situations like this, you got to know what to do right away, and that's perfect, Matt. What you said is exactly what we did. Actually, Adam and I treated this patient together.
That's a lucky kid to have the two of you in there.
We intubated this kiddo right away.
Yeah.
And then as we were able to assess the kid further,
Then
there
you're
were some
looking
other
at, okay, we
injuries.
got the airway, we're good, right? Obviously, we're going to keep him sedated. All that kind of stuff. Now we're looking at volume replacement, right? Burns, trauma. We're doing a head-to-toe assessment. Does he have any other
those
visible
clothes off.
injuries? Distended abdomen, any other, what do my vitals look like? Full set of vitals, all that kind of stuff. That's where I'm going from there.
Awesome.
Yeah.
You did the first thing great. It's perfect. I mean, you have to do first things first with these kiddos.
Have to prioritize.
Yeah. And we did that. We got the fluids going. We're the full assessment. We found some other injuries, the collapsed lung, and we got the kiddo stabilized to the CT scanner.
Did you dart it, or did you put a chest tube onto?
Chest tube.
Yeah. Adam probably did that.
Yep. And ended up transferring this patient
to a pediatric facility. Yeah. And we talked about what facility would I have taken that first patient to.
Yeah.
Patient was stable, could take a ride, 20, 30 extra minutes to go to maybe a pediatric trauma center, right?
Yeah.
This kid, most protocols are going to say, because he's probably about to rest, he needs to go to the nearest emergency room to get stabilized.
That's right.
Right? No matter how cool we think we are
That's
as
correct.
paramedics, doctors have a lot more education, experience, and it's a more stable
tools,
environment.
yeah.
And tools, yes. They have nurses. There's a lot more help.
Get them
you can
stabilized right away,
Yes.
then we can get them transferred to where they
Exactly.
need to
Yeah.
go. You're right. That other kiddo, it's better to drive past some hospitals
Yes.
because even though the kiddo's stable, that kiddo needs to go to the OR.
Yes.
And those surgeons got to run that bowel,
Yep.
got to do that exam to make sure there's no intra-abdominal injuries.
Exactly.
If you take them to another hospital, if there was something more serious going on, you're just delaying definitive care.
Yep.
This is where things are difficult.
Oh, yeah.
There's some nuance.
Transport decisions are not easy. They take some practice. But, yeah, those critical kids, it all goes out the window. They got to
Yep.
go to the closest facility, whether that's ground, you're 5 minutes from one, or you're calling a helicopter because you're in a super rural area, and you got to get these kids to a higher level of care fast.
That's right.
But
So remembering your assessment triangle is
Yep.
always good for pediatric assessment.
have some sort of system in place, whether it's hand heavy or using Broslow, whatever have a system in place to quickly be able to identify
Yeah.
dosages and things in these kids.
And
As I sneeze. Go
bless
ahead.
you. And
Thank you.
to know too when to get away from that typical assessment, to know when it's time to take immersion.
To do something.
Right.
Yeah.
We talked about it. Remember we went hiking that day?
Yeah.
We were talking
Yeah,
about
load
stay
and go,
play,
stay and play. Yep.
And knowing when it's appropriate to do both.
Yeah.
It's,
I'm not doing a full head to toe assessment on this burn kid.
No.
Like immediately. Like,
immediately.
no, this
Take care
kid,
of it.
if I take time to do that, the kid's going to die. I have to control this airway right now or I'm going to lose it because it's a burn. It's going to swell up. He's going to go into respiratory arrest. I've got to do this right now. I'm not worried about if he's got a femur fracture.
Right.
I'll worry about that in a minute. I mean, that's my thought at least. So,
No, that's
anyway.
good. Well, we talked a lot about the anatomy being different, the physiology being different with kids. We talked about the assessment with the triangle. We talked about the hand-heavy system, and we practiced on a few patients.
Yep.
Super important patient population. We got to be really on point and good in practice, like
Yes.
we talked about.
Get this more into your system one thinking, not your system two thinking, and that'll help you perform better on the call.
Because
So,
the best way to prepare for those unexpected calls is to over-prepare.
that's right. See you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.